Dear students, this is the last lecture of the upper limb. Today we have regional anatomy. The major regions of the upper limb are axilla, cubital fossa and carpal tunnel. The axilla or armpit is a fat-filled pyramid-shaped space between the upper part of the arm and the side of the chest wall. It contains the brachial plexus, axillary vessels and lymph nodes. It also acts as a tunnel for neurovascular structures to pass from the root of the neck to the upper limb and from the arm to the neck. Groups of lymph nodes within it drain the upper limb and the breast. The study of axilla is clinically important because axillary lymph nodes are often enlarged and hence routinely palpated during physical examination of the patient. The axilla is a pyramid-shaped space and we can describe four surfaces: anterior, posterior, median and lateral, and base and apex. Apex, also known as the axillary inlet, is formed by lateral border of the first rib, superior border of the scapula and the posterior border of the clavicle. Base or floor is formed by the axillary fascia and skin. In both pictures, the red color represents the anterior wall of the axilla. The anterior wall contains the pectoralis major, pectoralis minor, and the subclavius muscles. The green one is posterior wall formed by the subscapularis, teres major, and latissimus dorsi. The blue one is medial wall. Medial wall consists of the serratus anterior and the thoracic wall, ribs and intercostal muscles. And the smallest one is lateral wall in yellow color. It is formed by intertubercular or bicipital groove of the humerus. The size and shape of the axilla region differ with arm abduction. It decreases in size most markedly when the arm is fully abducted. At this point, the contents of the axilla are at the most risk of injury. The contents of the axilla are axillary artery, axillary vein, brachial plexus, biceps and coracobrachialis, and axillary lymph nodes. In the middle of the axilla we have axillary artery, medially we have axillary vein, lateral, medial and posterior from axillary artery we have lateral, posterior and medial course of the brachial plexus, and around arteries and veins we have axillary lymph nodes. In left picture you can see relationship between the axillary artery and vein. The axillary artery have a central position in the axilla and medially we have axillary vein. In right picture you can see the relationship between the cords of the brachial plexus, axillary artery and vein. Around the axillary artery, lateral we have lateral cord, posteriorly we have posterior cord, and medially we have medial cord of the brachial plexus. Medial cord lies between the axillary artery and axillary vein. We can repeat now that the axilla is pyramidal shaped space with base, apex and four walls: anterior, posterior, medial and lateral walls. Inside we have central axillary artery, medial we have axillary vein, and around the axillary artery we have lateral, posterior and medial cords of the brachial plexus. Inside the axilla we have 5 groups of lymph nodes. On the dorsal side of the pectoral region we have triangular space or blue one and quadrangular space or red one. On the posterior side of the arm we have triceps hiatus or green one. The borders of the omotricipital foramen or triangular space are: inferior border forms superior border of the teres major, superior border form inferior border of the teres minor, lateral border form medial border of the long head of the triceps. Inside we have circumflex-scapular artery and vein. The borders of the quadrangular space are: superior border forms subscapularis, inferior border forms teres major, lateral border forms surgical neck of the humerus, and medial border forms long head of the triceps. Inside we have axillary nerve and posterior circumflex artery and vein. The borders of the triceps hiatus or lower triangular space or humerotricipital foramen are: lateral border form shaft of the humerus, medial border form lateral border of the long head of the triceps, and superior border form inferior border of the teres major. Inside we have profunda or deep brachii artery and radial nerve. On the ventral side of the pectoral region, we have the clavipectoral triangle, also known as the deltopectoral triangle. We have three borders. Medial border form clavicle. Inferior border form lateral border of the pectoralis major. And superior border form medial border of the deltoid muscle. It contains the cephalic vein and deltopectoral fascia, which is a layer of deep fascia that invests the three structures that make up the border of the triangle. The deltoid branch of the thoracoacromial artery also passes through this triangle, giving branches to both the deltoid and the pectoralis major muscles. The cubital fossa is an area of transition between the arm and the forearm. It is located as a depression on the anterior surface of the elbow joint. The cubital fossa is triangular in shape and has three borders: lateral, medial, and superior. Lateral border form the medial border of the brachioradialis. Medial border form the lateral border of the pronator teres. Superior border is an imaginary line between the lateral and medial epicondyles of the humerus. The floor of the cubital fossa is formed proximally by the brachialis and distally by the supinator muscle. The roof consists of skin and fascia and is reinforced by the bicipital aponeurosis. Within the roof runs the medial cubital vein, which can be accessed for venipuncture. The contents of the cubital fossa include vessels, nerves, and the biceps tendon. From lateral to medial, we have biceps tendon, brachial artery, and median nerve. Lateral from the biceps tendon, we have radial nerve. Radial nerve is not always strictly considered part of the cubital fossa, but is in the vicinity, passing underneath the brachioradialis and divides into its deep and superficial branches. Biceps tendon runs through the cubital fossa, attaching to the radial tuberosity just distal to the neck of the radius. Brachial artery supplies oxygenated blood to the forearm. It bifurcates into the radial and ulnar arteries at the apex of the cubital fossa. Median nerve leaves the cubital between the two heads of the pronator teres. It supplies the majority of the flexor muscles in the forearm. The radial pulse is felt on the wrist between two tendons, lateral brachioradialis tendon and medial flexor carpi radialis tendon. In this groove, or pulse groove in Latin sulcus pulsus, radial artery descends from distal forearm to the hand. The anatomical snuff box, also known as the radial fossa, is a triangular depression found on the lateral aspect of the dorsum of the hand. It is located at the level of the carpal bones and best seen when the thumb is abducted. The anatomical snuff box has three borders, a floor and a roof. Ulnar or medial border form tendon of the extensor pollicis longus. Radial or lateral border form tendons of the abductor pollicis longus and extensor pollicis brevis. Proximal border forms styloid process of the radius and retinaculum musculorum extensorum. Floor form carpal bones, scaphoid and trapezium, and roof form skin. In the past, this depression was used to hold snuff, ground tobacco, before inhaling across the nose. The main contents of the anatomical snuff box are radial artery, a branch of the radial nerve, and cephalic vein. In superficial layer, we have cephalic vein and superficial branch of the radial nerve. In deep layer, we have radial artery and branch of the radial artery. The pulsation of the radial artery can be felt in the anatomical snuff box. The tenderness in the anatomical snuff box indicates fracture of the scaphoid bone. The cephalic vein at this site is often used to give in intravenous fluids. The superficial branches of the radial nerve can be rolled over the tendon of extensor pollicis longus. The carpal tunnel is a narrow passageway found on the anterior portion of the wrist. It serves as the entrance to the palm for several tendons and the median nerve. The carpal tunnel is formed by two layers, a deep carpal arch and a superficial flexor retinaculum. The anterior surface of proximal and distal carpal bones forms a concave surface which forms the deep carpal arch. The deep carpal arch is converted into a tunnel by the overlying flexor retinaculum. Look at the right picture and you can see how we have two layers of the carpal tunnel. Posterior layer form the carpal bones and anterior green layer form the flexor retinaculum. Now look laterally how the fibers of the flexor retinaculum splits and divides this large space into two compartments. Number 2 is the small lateral compartment for the tendon of the flexor carpi radialis, and number 1 is the medial large compartment or carpal tunnel. Now look at the left picture. Inside the carpal tunnel we have long tendons and median nerve. Deeply posteriorly we have 4 tendons of the flexor digitorum profundus and 1 tendon of the flexor pollicis longus. In front of these tendons we have 4 tendons of the flexor digitorum superficialis, and in front of these superficial tendons in the middle we have median nerve. Now look medially, superficial or in front of the flexor retinaculum, we have another canal, ulnar canal or canal of Guyon, for the ulnar artery and ulnar nerve. A deep laceration on the radial side of the wrist, as in a suicide attempt, may cut the following structures from lateral to medial side: radial artery, tendon of the flexor carpi radialis, tendons of palmaris longus and flexor digitorum superficialis, and median nerve. A deep laceration on the ulnar side of the wrist, as in a suicide attempt, may cut the following structures from medial to lateral side: tendon of flexor carpi ulnaris, ulnar nerve, and ulnar artery. Carpal tunnel syndrome occurs when the tunnel becomes narrow or when tissues surrounding the flexor tendons swell, putting pressure on the median nerve. These tissues are called the synovium. The synovium lubricates the tendons, making it easier to move your fingers. When the synovium swells, it takes up space in the carpal tunnel and over time crowds the nerve. This abnormal pressure on the nerve can result in pain, numbness, and weakness in the hand. Now we finish upper limb. Please, if you have questions, send me email.